on your records or not?
Excuse me?
Do you usually have that day in your records? I mean, St. Valentine's Day?
I have no plan for this year, so.
Okay. Sounds good. What time is it? Oh, we still have a couple of minutes.
Yeah, it's maybe 4 minutes before 6 p.m.
Yes.
So let's wait for more people.
Yes. Some people is joining, besides some other people is attending, I think, via YouTube. I'm not seeing Imad, the organizer. Probably
his name is LNH here, Imad, right?
Yeah, probably yes. He used to join as Imad, but probably he changed. Anyway, probably he will leave us as coordinators, both of us in the.
That's all right.
And I see also Leo he's from Argentina, and also Claudia. Okay.
So it's Valentine's night for us here in Bangkok. So not many. I did not expect many of audience from here in Thailand.
Okay, I understand.
Hi, Leonardo.
Yeah, Leonardo is here. So we usually have around 50 people, something like that, direct in the webinar. But as you know, yeah, it's summertime also here in the Southern Hemisphere. So particularly in South America, it's summer vacation, typically at this time of the year. So probably some people is on holidays.
Yeah. So after tibial nerve, do we have any more nerve following?
Yes, let me see. I have the list here. We have only one nerve missing, which is the facial nerve. It's going to be the next time. The facial
nerve.
Yeah, that's probably going to be with a heavy attendance because of the type of nerve involved. Also, many neurosurgeons, general neurosurgeons, or skull-based neurosurgeons will be involved in this last activity, which is going to be March the 7th. And then on April, in order to close, we add another talk by a doctor, anatomist and neurosurgeon called Thomas from Eastern Europe, who's going to speak about a new anatomy system in 3D dimensions, which is free software in order to be used by anyone. So that's going to be also an interesting activity. By then, we will finish with these webinars on anatomy.
So you start with a new series?
I will start with my retire. I don't know. I've been involved with this activity by chance. I was invited to participate in a bigger committee holding skull base and other anatomy, vascular anatomy, and all that. But probably this will end by now, by the moment. I'm not sure. So I think we are now we are 15 and it's 8. You what do you think? You wanna?
Yeah, we can start.
Okay. Well, let me good morning, evening, afternoon, whatever wherever it is in the places where people is watching this webinar. Welcome. I'm going to introduce my colleague and friend, Jitpun from Bangkok, Thailand. He's a neurosurgeon, specially trained in peripheral nerve, also in pain and spine surgery as neurosurgeon. He's a rising star in thanks, Imad. He's a rising star in the world peripheral nerve surgery. I can assure about that because he's working very actively in the WFNS committee, holding many promotional and scientific and academic activities. So I'm very glad to have his presence today. Jitpun, he's a neurosurgeon at the Neurological Institute in Thailand. And well, he's going to speak about the tibial nerve anatomy and its surgical implications. So thank you, Ekka, once again. We all call him Sheikh. Thank you once again, and please.
Okay, let me share my slide. Do you see it?
Yes, perfectly.
Okay. Okay, so first of all, thank you, Mariano, for having me in this talk about the tibial nerve. And thank you for your kind introduction. So let's start. So our talk today would be focused on the tibial nerve anatomy and the surgical approach. I have no disclosure, but before we begin, I would like to give a special thanks to our friend, Dr. Carlos Rodriguez, my good friend, and Dr. Banpot Sitinam Suwan, one of my mentor, for giving a lot of image and resource I use a lot in this talk. So let's begin with the origin of the tibial nerve. The tibial nerve, as you know, is originated from the anterior division of L4S3 ventral rami of the lumbosacral plexus. It is good to note that while the anterior division form the tibial nerve, the posterior division of the ventral rami form the peroneal nerve. The tibial nerve and the peroneal nerve runs together to become the sciatic nerve, while the tibial portion is larger and is lying on the middle side of the sciatic nerve. So at the buttock level, the nerve exits the pelvis via the greater sciatic foramen. Do you see my pointer here? So most of the case it lies inferior to the piriformis muscle, but you know there are variations. Some of the nerve just pierce through the piriformis muscle, or some just exit above the piriformis muscle. There are variations in that. So since we have recently have a dedicated talk on the sciatic nerve, I would not dive into much detail about the buttock level. The tibial portion gives off no branch at this level. Most of the muscle in the buttock area are innervated by the direct branch from the sacral plexus. Then the nerve runs straight and midline in the thigh. At the proximal thigh level, the tibial portion gives off so many muscular branches to supply the hamstring muscle and part of the adductor magnus muscle. So let's see at the thigh level, the hamstring muscle. The main function of the hamstring muscle is to do the knee flexion. It composes of 4 separate muscles. On the middle side, you got the semi-membranosus and semi-tendinosus. And on the lateral side of the nerve, you got the long head of bicep femoris and the short head of bicep femoris. Interestingly, the tibial nerve do not innervate all of them. It's just innervated 3 of them. The tibial nerve innervates the semi-tendinosus and the semi-membranosus on the medial side, and the long head of bicep femoris on the lateral side. But the short head of bicep femoris that lying deep to the long head is innervated by the peroneal nerve. And the adductor magnus is innervated by 2 nerves. on the medial head, which is highlighted here in red, is innervated by branch from the tibial nerve, while the lateral part is innervated by the obturator nerve. It adducts the hip. So before entering the popliteal fossa, the sciatic nerve is divided into the peroneal nerve and the tibial nerve. The tibial nerve here continue to run in the direction of the main sciatic nerve trunk into the center of the popliteal fossa. But at the proximal of the popliteal fossa, the nerve lie lateral to the popliteal vessel. But then at the popliteal fossa, the nerve cross above the vessel and lie on the middle side of the vessel in the distal part of the popliteal fossa between the two heads of gastrocnemius here. At the popliteal fossa, the tibial nerve gives off a sensory branch called the medial sural branch. The nerve, which is highlighted here in orange, the nerve will join the lateral sural nerve from the peroneal part to form the sural nerve trunk. And another group of branch that take off from the tibial nerve at the popliteal fossa is the articular branch that innervate the knee joint. The highlight here in orange, the supromedial and inframedial genicular nerve that innervate the medial and posterior part of the joint capsule. The location of this articular branch take off from the tibial nerve is quite variable, from many centimeters above the knee or within the popliteal fossa. These branches are important if you are surgeons or pain specialists who do the pain intervention to treat knee joint pain by doing the nerve blocks or the radiofrequency ablation. At the popliteal fossa, the tibial nerve gives off many more the branch that supply the muscles that function as ankle plantar flexor. It flex the ankle in the plantar part. On the medial side, it gives off a branch to innervate the medial head of gastrocnemius. But on the lateral side, it gives off so many branches that innervate the many muscles, including the lateral head of gastrocnemius, the soleus, and the popliteus. So after the popliteal fossa, the nerve runs in the midline, deep under the arch of soleus, but it remains superficial to the deep posterior compartment muscle. So in the proximal leg, it runs dorsal to the tibialis posterior muscle. And in the distal leg, it runs in the groove in the cleft between the flexor digitorum longus and the flexor hallucis longus, along with the tibial artery and vein. So it's quite straightforward. The tibial nerve is quite have straight pathway. At the ankle level, it runs posterior to the medial malleolus and entering the foot by running deep to the flexor retinaculum or laciniate ligament that bridge the medial malleolus and medial calcaneus. This retinaculum form the roof of the tunnel called the tarsal tunnel. So the tarsal tunnel has important structures from the anterior to posterior, which is the tendon of tibialis posterior on the most anterior part, followed by the tendon of flexor digitorum longus and the posterior tibial artery and vein, followed by the tibial nerve, and the most posterior part is the tendon of flexor hallucis longus. So if you see at the foot level, at the level of tarsal tunnel, it bifurcates into three terminal branches: the medial plantar nerve, the lateral plantar nerve, and the medial calcaneus nerve. The medial plantar nerve is the most anterior part of the branch. It supplies the intrinsic foot muscle and sensory to the medial sole. And the lateral plantar nerve, it also supplies the deep foot muscle, and it also provides sensory innervation to the lateral part of the sole. And the medial calcaneal nerve, which is the supply the sensory to the medial heel. So it runs under the adductor hallucis to enter the plantar of the foot, which is this muscle. So at the plantar of the foot, you can see here that Each medial and lateral plantar branch bifurcate into motor and sensory branch, supplying a lot of intrinsic muscle of the foot. These muscles are quite difficult to isolate it on the examination. Thanks for my resident here, he's a model. So you can see that the function of the tibial nerve, the first function is the knee flexion by innervating the hamstring muscle. To test the hamstring muscle, the patient can maybe sit, and you test the muscle that let the patient flex his knee. This is the function of hamstring muscle. And another function of the tibial nerve is the ankle function. The first, my resident always have a problem in testing the function of the ankle because they know very well about the innervation by the dermatome or myotome. But when you ask about the nerve, they just confused. They don't know which one is supplied by the peroneal nerve, which one is supplied by the tibial nerve. But this is, I will summarize here, is quite easy. So the ankle dorsiflexion here is functioned by the muscle called the tibialis anterior and supplied by the deep peroneal nerve. And the next one is the toe dorsiflexion, which is the EHL. Sorry, it's skipped. Supplied by the deep peroneal nerve also. Sorry. So the next the ankle plantar flexion is supplied by the muscle, is functioned by the muscle of gastrocnemius and soleus that innervated by the tibial nerve. The ankle inversion is action by the tibialis posterior muscle, which is supplied by the tibial nerve. And the ankle eversion that's supplied by the peroneus longus and peroneus brevis is supplied by a superficial peroneal nerve. And the last one is the function of the toe fingers and cupping of the foot that also act by the muscle of flexor digitorum and the intrinsic foot muscle. This is supplied by the tibial nerve. And for the sensory function, as you know, most of the lateral leg is supplied by the peroneal nerve. The tibial nerve actually is only supplied by the kind of plantar side of the foot. The medial plantar nerve is supplied on the medial side of the sole, and the lateral plantar nerve is supplied on the medial plantar nerve supply the medial part, and the lateral plantar nerve supply the lateral part, and the medial calcaneus nerve supply the calcaneus, the high sole on the medial side, and the sural nerve supply the fifth finger. So I finished with the branching and anatomy. So the next portion is the surgical exposure and the case illustration. So here at the buttock level, exposing the sciatic nerve can be done by the mainly two approach. The first one is the classic buttock incision and sciatic nerve exploration. You create the big wound and cut the muscle bulk of the gluteus maximus as its insertion. I have applied this exposure in a few cases. It's quite easy to explore the nerve, but for the patient it is quite painful because the scar is quite big, and the patient will need quite a long recovery time. Another approach can be done via the transgluteal approach using a muscle splitting technique as published by Dr. Moreno in 2011. This is not as painful as the classic one and give the patient faster recovery. And the exposure is not that bad, just in case you just do the, you want to explore the sciatic nerve in the buttock region. This is the example. This is a case of I performed surgery in a case with piriformis syndrome. the incision is marked in the midline buttock, but in this case, I center the incision at the location of maximal tenderness. Sometimes I use ultrasound to identify the piriformis muscle and the sciatic nerve to plan the skin incision just for precision. After you open the skin and dissect through the subcutaneous gluteal fat, you find the gluteus maximus muscle. Then you open the muscle sheet and split the muscle fiber without cutting the muscle. In some patients, the fat and the muscle might be deep, so you will need a good long retractor and maybe two assistants to do the muscle retraction. Then you find the fat underneath the muscle, which is lying here, the subgluteal fat plane. The nerve will be here. The nerve is always in the fat plane. So you can dissect the nerve distal beyond the gluteal fold. From this approach, you can dissect proximal just to the piriformis muscle and dissect down to the gluteal fold, about maybe more than centimeters long of the nerve exposure. But if the exposure is not enough, so you can extend the incision, extend the lesion by the subgluteal and proximal thigh level approach. You can extend the linear midline incision at the upper thigh like this. The sciatic nerve will lie between the plane of biceps femoris on the lateral side and the semitendinosus on the medial side. As you see here, you can separate the tibial portion on the medial side and the peroneal portion on the lateral side. The tibial nerve is much bigger than the peroneal. This is a case example. In this case, the patient have spastic quadriplegia after the spinal cord injury, and the lower limb are non-functional. The patient was bedridden and cannot sit on wheelchair because of spastic hip flexion, hip adduction, and knee flexion. This is the resting position of the patient. This is the case. We try to release the muscle from where he. You can see now is the posture in this position. So she cannot afford vertical baclofen therapy. I think this is the common problem we found in developing country. Not many of our patients can afford quite the expensive instrument. So I choose to do ablative surgery in this case, including the selective neurotomy of the bilateral tibial branch to hamstring to decrease the spastic knee flexion, combined with a bilateral neurotomy of the anterior branch of the obturator nerve to decrease the spastic hip adduction and hip flexion. So here, I made the incision here at the midline subgluteal region, split the plane between long-headed biceps femoris and the semitendinosus, so keep in the midline. So now you can identify the sciatic nerve here. Then I used electrical stimulation to identify motor branch to the hamstring muscles. Because the patient has non-functional limb, I cut all the motor branch to the hamstring. So the main tibial nerve trunk was preserved. Here is the surgical video as I try to stimulation. This is when you stimulate the tibial nerve trunk, you see the plantar flexion of the ankle. It's quite a bit long, okay? And then you see the branch that take off from the tibial nerve, and you can see the contraction of the hamstring muscles. So in this case, the patient is non-functional. So I cut all the branch to the hamstring muscles. Here is the long-headed bicep femoris on the red loop. This is the semi-membranosus on the medial side. So you cut all these into segment, 1 centimeter segment, to prevent a re-innovation in the future. So on the left side, the pre-op resting position. On the right side is the post-op resting position. You can see here we can treat the spasticity by you turn the motor neuron lesion into the lower motor neuron lesion and help with the patient in the future. She might can sit on the wheelchair because so right here you cannot sit on this position. So the next one is the exposure at the popliteal fossa. To expose the tibial nerve as the popliteal fossa, you can make a midline incision, but you have to avoid perpendicular incision across the popliteal fossa because it might cause scar contracture that can lead to flexion deformity. I'm so serious about this one because most of my case are the patient with spasticity, and if you made the incision and you cause more scar contracture, the patient might have more problem with spasticity and deformity. So I recommend at least a lazy-S incision or the incision that parallel with the popliteal crease I show you later. For example, is the case illustration here by Dr. Banpot, Sitinamsuwan. The patient has spastic plantar flexion and difficulty in walking that caused by the cerebral palsy. The motor function of the ankle plantar flexion. Hello?
Not sure. Sorry to interrupt. I'm not sure if you're sharing your screen, at least.
I'm sharing my screen. Can you see that? We're still sharing.
Okay, I'm sorry. Then go on. I'm sorry.
Okay.
Maybe it's my
can you see me?
Yes, definitely.
Okay, sorry.
Okay.
I begin with this slide. Okay. This is a case with the patient has the spastic plantar flexion and difficulty in walking that caused by the cerebral palsy. So the motor function of ankle on the right side here, on the plantar flexion and the ankle dorsiflexion is still preserved. As I mentioned earlier, you should avoid perpendicular incision across the popliteal crease and prefer a parallel incision at the popliteal crease instead. If you do the transverse incision, you are also able to identify the branch to the tibial nerve at the popliteal fossa. And it's possible if you want to extend the length of exposure up and down the popliteal crease. So you can see here, you can identify the motor branch, the nerve to medial and lateral gastrocnemius, the nerve to soleus, the distal main tibial nerve trunk, and the medial sural nerve. The patient ankle and foot motor function is still intact. If you cut the whole motor branch in the same way I did in the previous case, the patient would wake up with weakness of the foot plantar flexion. So what you need to do is to maybe partially cut the motor fascicle in the targeted nerve. For this case of ankle plantar flexion spasticity in the picture here, you will identify the nerve to soleus, for example, in the picture A. You can open the epineurium and perform intrafascicular dissection and use electrical stimulation to identify motor branch and cut some of the motor branch, but not all. Then you repeat the procedures on all the nerves that innervate the muscle that act as the ankle plantar flexor, just like medial gastrocnemius and lateral gastrocnemius. This is different from the first case in that the patient limbs are non-functional. In the functional limb, if you totally cut the motor branch, the patient will wake up with the motor deficit. So here we cut about 50 to 70% of fascicle in each nerve. If you do the open the fascicle and you see 4 fascicle in that nerve, you may cut 3 of them, not all. And you can monitor by the reduction of 50 to 70% of the amplitude of the CMAP. Here in the A picture, this is the compound muscle action potential in the pre-neurotomy before you cut the fascicle. And in the B side, this is the post-neurotomy. You cut some of the fascicle and target the reduction of the 50 to 70% of trigger compound muscle action potential amplitude. So by this approach, you can treat spasticity and preserve the function of ankle plantar flexion. In the proximal calf level, you can extend the midline incision down from the popliteal fossa. The nerve will lie between the medial and lateral gastrocnemius, just like this. Then it dives deep under the arch of soleus, and it might be deep, or need muscle resection to expose the tibial nerve that lies under the gastrocnemius and soleus. So there are another approach, other alternative. It can be done by the incision in the medial calf. It can be done like this. The steps in the fasciotomy, you perform a linear medial incision at 1 finger breadth behind the edge of tibia. Then you open the muscle sheet and separate the plane between the superficial and the deep posterior compartment. The superficial compartment here is the soleus muscle and the medial gastrocnemius, and the deep posterior compartment is the flexor digitorum longus here. Then between the plane, you can identify the tibial nerve and the tibial vessels. One potential pitfall for this approach is that you're entering the wrong plane. If you develop a plane between the gastrocnemius superficially and the soleus here, you will not find the tibial nerve. You go to the wrong plane. The right plane would be in the plane between the soleus and the flexor digitorum longus. The last one of this talk about the approach and the exposure is the exposure of the posterior tibial nerve at the ankle level. It has been used in case of tarsal tunnel syndrome decompression. So here you can palpate the medial malleolus and the medial calcaneus. The incision can be made between these two bony landmarks. After you open the skin and dissect the subcutaneous fat, you can see the white fascia here. The fascia that runs between the medial malleolus and the medial calcaneus can be thick and compress the neurovascular structure underneath the tarsal tunnel. So now you can cut the flexor retinaculum here and preserve the underlying neurovascular structures. After the section of the flexor retinaculum, you can identify the tibial nerve running posterior to the tibial artery and vessel. Then you dissect the nerve distally, and you will see the branching of the distal tibial nerve. The most anterior part is the medial plantar nerve, and behind that is the lateral plantar nerve, and the most posterior that run into the calcaneus is the calcaneus branch. So the distal part of the nerve will run underneath the adductor hallucis, which is retract here. You have to retract the adductor hallucis up, and you see the white fascia here underneath. After you retract the adductor hallucis, you have to cut the fascia covering the nerve to cut all the potential compression point to totally decompress the nerve. So this will be the total decompression of the tibial nerve at the ankle level. So in summary, the tibial nerve is quite straightforward in exposure. In the upper part, in proximal part, in the gluteal region, in the thigh region, and in the popliteal fossa, just keep in the midline. But in the calf, you can do the medial approach by the incision about 1 finger breadth from the medial edge of the tibia. And in the ankle, you can do the exposure by the incision in the midline between the medial malleolus and calcaneus. So this would be a short lecture. So thank you. Any questions?
Excellent. Can you hear me?
Yes, but Let me see. I cannot see your face. Okay.
Oh, you're not missing anything. Don't worry.
Okay.
Okay, so very interesting talk. Thank you very much, Jake, for this wonderful presentation. Maybe the tibial nerve is not so well known in the medical literature. You hear the facial nerve, as we talked before, the sciatic nerve, the median nerve, but the tibial nerve is not very popular. But I would say it's quite important for many reasons, like sural nerve harvesting, tibial compression for diabetes and decompression, and for spasticity, for many other things. So a good knowledge of the tibial nerve is quite important, and also its main function, as you also mentioned, is sensory. So the main target is not to reinnervate the motor tibial nerve, as we always do with the upper limb, for instance, but the sensory aspect of the tibial nerve is quite important. As an important message, maybe would be that one. Let me ask you a couple of questions, and then we can, if someone in the audience wants to pose a question, of course, will be welcome. The first question is that you show very interesting cases on spasticity. Let me ask you, how do you measure, besides the first case, when you section everything because you didn't mind, because of the problems of the patient, the handicap of the patient itself. But let me ask you, how do you measure the percentage of nerve sectioning that you do? Do you open completely the branches and then you section? Please tell us.
Right.
Thank you.
This is quite challenging, because if you cut it all, you cut all the motor branch, the patient will have no motor function. But you can do that in the patient that you are quite sure that there is no function left. For example, is there is the movement, spontaneous, I mean the voluntary movement of muscle at all. You can cut all the all the nerve. But in the patient with preserved function and the patient have spasticity, this is quite challenging to measure how many fascicles you will cut, because if you cut just few fascicles, just for example, you do the open the epineurium and you see 4 fascicles, and you cut only 1 or you cut only 2, you cannot know if the patient will be improved by your operation. Sometimes the patient still have wake up with the spasticity. So it is the quite common, because you know, for me, I have a problem with cutting not enough, more than cutting more than enough. So I prefer to cut about I would say 3/4. If you open the fascicle and you see the, if you open the epineurium and you see 3 fascicles, for example, I cut the most active one, the most 2 active one, 2 of 3, 2 from 3. If you open that and you see 4 fascicles, I cut 3. Just leave 1 functioning motor function left. So this is if you don't have any monitoring. But if you have monitoring, you have the needle EMG for say, I do measure the amplitude. You stimulate the muscle, you stimulate the nerve, and you see the amplitude, and you maybe cut 1 and you see the amplitude of the rest, and you cut 2 and see the amplitude of the rest. If the amplitude lower more than half, or about 75%, that is maybe more satisfying. So that's how I choose to about the measurement of the resection of the neurotomy.
So you said that you have more fear of cutting less than of cutting more. So I assume that you you've seen on your patients some, let's say, I wouldn't say recurrence, but reinstallation of the spasticity with long follow-ups. Is it true? Is it what you see to regain spasticity?
Right. Because most of the case, in some case, you need reoperation because the patient is not improved enough of the spasticity if you cut less than expected. But yes, beware if you cut all of the functioning fascicle, the patient have weakness. They will feel weakness. But comparing about for the spasticity, because those patients cannot walk properly anymore because you see they are in this posture, and they cannot walk normally. But if there is weakness, yes, they can feel weakness, but sometimes they can wear the AFO, the ankle foot orthosis, and they can walk properly. Because in this position, they cannot wear the ankle foot orthosis at all. But if there is weakness occur, yes, they can wear the ankle foot orthosis. And I would say sometimes I have to consult the orthopedic surgeons to do the I would say the gastrocnemius lengthening procedure, because some of the patients have prolonged spasticity, and just cutting the nerve is not resolve their posture. You have to do something with the gastrocnemius tendon. Maybe
Yes,
lengthening.
I understand. Yes, as a coaptation. So you do first the lengthening and then you do the cutting of the nerve, or you do both procedures at the same moment?
Usually you can evaluate that after the general anesthesia. If the patient have no fixed posture after the general anesthesia, maybe cutting the nerve is enough. But if the patient have the fixed deformity after the general anesthesia, maybe you need orthopedic surgeons to do the tendon lengthening.
Okay. Also, our dear common friend Carlos is asking, how is your protocol in order to decide whether to operate or no spasticity via a partial or a complete neurectomy? Can you tell us how is your protocol?
My protocol is I see the primary lesion. If the lesion is, you see the complete, let's say, spinal cord injuries, complete spinal cord injury, the patient have no sensation and no motor function, and most likely the patient have the ACIA of spinal cord injury. That's this patient I prefer to cut all the motor branch.
Okay.
Of course, it is not perfect because in developed country they do the baclofen pump. It is the first line, but in some situation in developing countries, people cannot afford the baclofen pump. For me, I would say baclofen pump would be the first priority in generalized spasticity. But if the patient cannot afford the baclofen pump, yes, I do the maybe neurotomy.
That's in generalized spasticity. Okay.
Right.
In segmental spasticity, the one that you cannot use the baclofen pump.
Right. In generalized, I choose the baclofen pump first. But in
Yes.
segmental spasticity, just like maybe this case,
Yes.
I prefer, because it's segmental, as this is quite generalized. I mean, if in this case, if the patient can afford the baclofen pump, I do the baclofen pump first, right? But for this one, this is like a focal,
Yeah.
and baclofen pump would not, I think is the indication for this case. Is a focal spasticity, and the patient is still can do the ankle dorsiflexion and plantar flexion voluntarily. In this case, this is usually from the cerebral palsy. I will not cut it all. I preserve some function for the patients.
Okay. Okay, well, very positive reactions to your talk. A lot of people is congratulating you, Eka. So
Thank you.
once again, congratulations. Isadora is asking, how long after the surgery can the patient walk? Is it recommended any kind of immobilization? Talking about this same surgery, of course, spasticity surgery and neuro.
After the surgery, I recommend early rehab, early mobilization. I will not put the patient in splint anything, because you try to treat spasticity, you try to treat the deformity, and if you do the splint after the surgery, the patient will have some degrees of joint stiffness or something like that. So I prefer the patient to do early mobilization, early rehab.
Great. Also, Ibrahim is asking, which is the approach for, sorry, cutting the anterior branch of the nerve, which is the approach
The
that you...
obturator nerve, I do not insert it here. Let me see if I can check.
Okay, perfect. Take your time.
Let me see. Just give me few minutes, because it's the obturator nerve, and I do not put the picture here, but I have.
Yes, but since Ibrahim is asking, maybe it's interesting, and they are all interested in spasticity. Maybe we should organize a talk just in neurotomies for
about
spasticity.
Yeah, sure. And maybe the obturator nerve is another nerve that is interesting, because sorry, I think I cannot. Let me see my internet, because you are on Zoom and the Google seem to be quite slow. I don't know if I can do it, but let me show you here. I share this one. Let me stop sharing, and I open another.
Of course, yes. Go ahead.
Yeah, sorry. Let me see if I can open it. It seems it's not functioning good. Let me talk then. So here is the incision. You open the incision on the medial thigh, on the medial side. I use ultrasound to identify the plane of the nerve. Then you do the linear incision to the correct plane, because if you can do the muscle kind of muscle landmark, but sometimes I waste my time. I'm a newbie, I'm a beginner. I don't waste my time finding the plane, the right plane. So I do the ultrasound to find the right plane of the obturator nerve. Then
Which
I
is the
make
right
the
plane?
linear incision.
What
Then
are
I
the
made a
landmarks that you use?
Oh, sorry, I did not share so I made the linear incision.
Which are the landmarks that you use under ultrasound?
I see this is the nerve would be between the anterior adductor hallucis, the adductor. Let me check. The adductor magnus on the posterior part, and the nerve would be between the adductor magnus and the superficial part of the adductor muscle. It's quite where it's not that difficult, I would say, because it's in the plane, just like every nerve is in the plane between the muscle. And if you do open and approach in the right muscle plane, it would be easy to find. The obturator nerve will have the anterior branch and the posterior branch. The anterior branch would innervate the the anterior part of the adductor muscle, and the posterior branch will innervate the adductor magnus. So I cut only the anterior branch, and sometimes I cut the muscle, because
You do a
tenotomy. Yes, I not just cut the nerve, I cut the muscle.
At what part of the muscle? At the same part where you are cutting the nerve, more distally, more proximal?
Yes. No, it's just cut at the tendon. The insertion of the tendon that insert into the obturator, the bone.
Okay.
Okay. And you see here, you might remember that the adductor muscle, the obturator nerve, do the hip adduction. But actually, it have the function in the hip flexion. You cut the obturator nerve, you see the some improvement of the hip adduction. So hip flexion, sorry. Because if you remember, the hip flexion is mainly from the iliopsoas, and I would say this is impossible to cut to do the iliopsoas neurotomy, because it's in the pelvis, and you cannot open the pelvis and cut the nerve to iliopsoas. So here you see the patient left with some of the hip flexion, but cutting the adductor muscle, cutting the nerve, obturator nerve, to innervate the adductor muscle, also improve the hip flexion.
Yeah.
This is you call here the scissor hip. In some patient, because the hip would be kind of crossed. This help the patient in that have the kind of deformity in that posture.
Okay.
Let me see if I can show you the. Sorry, I cannot.
Nope. Don't worry.
Yeah, maybe in the future I can show you.
Yes.
I can share you guys about the operator neurotomy.
Let me ask you, if you which incisions, whatever, do you use for sural nerve grafting?
I do. Previously, I do open.
Open. You
Very
open from
long.
one side to the other.
Previously, in
Okay.
my early practice, I do just open incision, long incision.
Okay.
But right now I use tendon stripper. I don't know if anyone use tendon stripper. You open the incision at the lateral
Malleolus?
lateral to lateral malleolus,
Yes.
and then you identify the sural nerve, cut it, and then use the tendon splitter, and along the nerve you can open, maybe usually some of the sural nerve have its branch. Then you pass the tendon stripper, and you cannot go beyond that. You open another incision, just like to find another the tendon strippers, and then you pass the nerve. It needs kind of 3 to 4 incision, but very small incision. So right now I prefer tendon strippers.
Perfect. And another question would be, do you believe, or do you do usually tibialis nerve decompression at the ankle for diabetic neuropathies?
I don't have many cases with tarsal tunnel syndrome. I would honestly, because because my hospital is quite a specialized hospital. There is no diabetes patients, so I do not have much case with tarsal tunnel syndrome. I don't
Okay.
know if the audience here have experience with the diabetes surgery for the diabetic neuropathy.
I'm asking
You
you
can
because
share.
it's a very controversial issue. Many people,
Yes.
me myself, I'm included, do not believe or do not see. It's not a belief. It's just there is no strong academical, methodologically
Evidence.
speaking,
Yeah.
evidence of the usefulness of this procedure used as a prophylactic measure to
Yeah,
decompress the nerve and preserve the patient from ulterior diabetic neuropathies. But I mean,
yeah,
many people, including the pioneer in this field, which is Lee Dellon,
yeah,
deserves attention, and many uh, I would say it's more popular among plastic surgeons
yeah.
than among neurosurgeons, these
I
procedures.
I I got you because the if you look at the pathophysiology of the diabetic neuropathy, is axonopathy. It's not myelin, just like a compression syndrome. It's very axonopathy. And open decompression, I don't know if it's improved the pain or it's improved the numbness. But
Yeah.
yes, if theoretically, if there is axonopathy and the nerve becomes swollen, yes, that might help. But I would say I think is in my mind. I do not have experience, but I think it might help, but it would not regain. I mean, do not cure the tibial neuropathy because it's the primary lesion is the axonopathy inside the nerve.
Yeah. In fact, Alan Bersberg did a nice Cochrane review of all the literature, and he didn't find very solid evidence supporting the use of this surgery as a prophylactic surgery. Also, Carlos also agrees. He states at the chat that no evidence to support this procedure. Nima is asking about tendon transfers. I don't know if you use or have any experience on tendon transfers. Uh, I assume that this is for steppage when you have a peroneal nerve injury and you use the
Yeah,
tendon transfer. You transfer the posterior tibial
yeah,
tendon in order to
yeah,
regain
yeah.
dorsiflexion. Do you have any
So
experience
so
on that?
I do not have experience, but I have a chance to read the papers by our friend Mahadi. He's in our committee. He reports 6 of the patients that do the nerve to soleus. He used nerve to soleus and transfer to the peroneal nerve.
Mhm.
And in his papers, I would say one third, only one third, two patients from 6 patients is improved, and the rest 2/3 is not improved at all. So I would say yes, it's an alternative. You can do it, but you have more reliable option. I would say if the tibial nerve is preserved, the posterior tibial nerve, the tibialis posterior tendon transfer to improve uh, the the foot drop is much more reliable. So I don't
Yes,
know about
I
evidence,
do
but
agree. We we don't have experience, but also Brazilian neurosurgeons like Mario Siqueira and his group from São Paulo, they also find the same results as Eman Hadi in a complete different continent, far away.
yeah,
So I think this nerve transfer is not very reliable, and we also have a big experience on tendon transfers, more than 100 patients, and I would say this is a very reliable surgery, more than 90% of good results. So I would recommend to go into this surgery in order to, there are some variations. You can use whether a rotational
yeah,
route or a transmembrane route to pose the tendon. You can fix the tendon to tendon. You can fix the tendon to bone. Many other different aspects, but definitely is the procedure of choice, the gold standard at this moment.
yeah,
Well, I think
and
we don't. Yeah, I'm sorry.
yeah. So and one more thing about the nerve transfer for the foot drop is that you have usually when you have the peroneal nerve injury, it would be at the very distal, maybe at the very distal part of the peroneal nerve, maybe at the fibula head, and you do soleus transfer, which is you cannot cross all the soleus to the at the insertion of the tibialis anterior, because the soleus nerve is not that long enough to do the distal transfer. The result is
So
not, I
you
would
might
say,
need a graph, which
yeah,
ends
you
up
might need a graph to do the
peritonealizing.
transfer.
Yes. Yeah, absolutely. Absolutely.
And it's
Yeah.
not reliable.
Absolutely. I completely agree. So, well, we have a good audience, and everyone stay till the end, which is now. So congratulations for this interesting session. Thank you very much once again,
Yeah.
Eka. Thanks everyone for being here with us. And well, we will find each other on facial nerve next month on March. Okay.
Yeah, thank you everyone. Thank you, Mariano, for having me. I'm enjoyed the talk, really enjoyed the talk. And thanks for everyone for staying here till the end.
Thank you. Bye bye.
Thank you everyone. Bye.